Good morning or good afternoon, everybody. Today we are here at Mayo Clinic in Rochester, Minnesota to talk about kidney transplantation and specifically about living donor kidney transplantation and especially about the living donor donation process. And we have with us Dr. Carl Kramer. He's a nephrologist, adult and pediatric nephrologist, and he's the director of the Pediatric Kidney Transplant Program. We also have Dr. Phil Fisher, who is a pediatrician here at Mayo Clinic, but he also donated a kidney. So he's going to talk to us about the experience, his personal experience as a kidney donor. And then I am Mikel Prieto. I'm a transplant surgeon. I'm the surgical director of the adult and the pediatric kidney transplant program here in Rochester. So let's just start by telling you a little bit about our transplant program. Obviously, kidney transplantation is for those patients who have their kidneys have failed to the point where they need a replacement. And there's two ways to replace the function of the kidney. One is with dialysis, a machine that basically does the functions of the kidney. And the other one is with a new kidney transplant from somebody else. Clearly, everybody agrees that the best option for a good quality of life and longevity is to get a kidney transplant. And specifically, we feel that a living donor kidney transplant has multiple advantages because it gives you a very good kidney, high quality kidney. You can get transplanted in a timely fashion, many cases before you actually need dialysis. So these patients go from having a failing kidney to going back to full health before they need dialysis. This is what we call preemptive transplantation. And clearly is the chances for having a good, long, healthy life is the best chances you have with a living donor kidney. So our approach at Mayo Clinic has been to basically try to maximize, to allow as many people as possible to get a living donor kidney transplant. How do we do that? Well, we emphasize, of course, to all our patients that come here looking for a transplant, the advantages of live donor transplantation and preemptive transplantation, which is what I just was telling you about. And of course, this includes facilitating living donation, educating patients and their families about the risks and benefits of living donation. We have been able to reduce some of the barriers to kidney donation. And of course, for many years, actually we did the first one in 1999, we are able to do laparoscopic nephrectomy, which means that the donor donates a kidney through a very small incision, and the recovery with this surgery is relatively quick. People go back to work and to normal life relatively soon, and represents less of a demand on the donor that it used to be the old-fashioned way where we had to make a big incision, remove a rib to get to the kidneys. So this has been a significant advantage. And the combination of removing some of the medical barriers to donation and doing the laparoscopic nephrectomy is what has allowed us to increase the number of living donors. In addition to that, some of the other things, and Dr. Kramer is going to start talking about some of those things, it's allowing us to continue to increase the number of living donors that we do at our hospital. Carl?
Hello, so this is Dr. Kramer, one of the pediatric kidney transplant physicians here. I'm going to go over some of a little more detail regarding how we at the Mayo Clinic are removing some of those barriers that Dr. Prieto talked about. So kind of the first thing is to try to address what we call immunological barriers, which is what Mayo has been at the forefront for the past decade, specifically looking at those that are what we call sensitized patients. In other words, those patients that have specific antibodies, or some people may be familiar with the term of a high PRA, and trying to address the best way to get those patients transplanted so they don't have to be on dialysis for prolonged periods of time. Another immunological barrier that was kind of a forefront here at Mayo a decade ago was also those that are ABO incompatible donors. In other words, the donor is one blood type and the recipient is a different blood type, and trying to kind of cross that barrier has been one of the things that we've addressed here at the Mayo Clinic. Another barrier sometimes is the age. So in other words, you have a father who is maybe 65 who wants to donate to his daughter who is 25. And sometimes that age discrepancy may not be the best option for the younger daughter. And so we here try to work with maybe trying to find other potential donors where the age is aligned better with the long-term benefits of the kidney transplantation. One of the other medical barriers that we've noticed over the years is some programs turn down people for their for high blood pressure. And here at the Mayo Clinic, we actually have a specific protocol to try to help allow those who have well-controlled high blood pressure to actually potentially donors to loved ones. And then the final category is addressing those barriers that are kind of classified as what we call cultural barriers, specifically having those that are unrelated donating to potentially kidney recipients. A classic example is we've seen teachers come forward to donate to their pediatric patients. We also have what we call non-directed donors, which Dr. Phil Fisher will give his perspective on. And then finally, we'll let Dr. Mikhail Prieto explain more about the paired exchange program. So just to kind of back up in regards to kind of how the overall process goes, as Dr. Mikhail said, the goal of transplantation is to give those people with end-stage kidney disease a better lifestyle and better long-term outcome. So the general overall theme is if you have end-stage renal disease, most people end up getting some sort of transplant evaluation. And in the majority of situations at other facilities, often they end up going on what's called a waiting list after they've had their initial transplant evaluation. They end up meeting with a surgeon to discuss access for dialysis, whether it be through hemodialysis or peritoneal dialysis. And then, unfortunately, a majority of them end up going on to needing dialysis. And then after on dialysis, they end up going on to get their kidney transplant, either a deceased donor or a living donor transplant. The other option is for them to get their transplant evaluation and before going on to dialysis, ultimately getting a living donor transplantation. And one step in between that process, potentially, which Dr. Prieto is going to discuss more, is entering into what we call the paired donor pool and then going on to getting a living donor transplantation with the whole goal of trying to avoid needing any sort of dialysis therapy. Here at the Mayo Clinic, we prefer to be very proactive and try to minimize those patients that need to go down through the dialysis approach. So here, we like to meet people when they're kind of at the later stages of stage 4, so their kidney function, is around 20–25%, and then enter them into the transplant evaluation process. From there, hopefully give them a preemptive kidney transplant, in which this case, the majority of them will be living donor, and on a rare occasion, sometimes even a preemptive kidney transplant can be done through the deceased donor program. The other option is also, in case you don't have a specific living donor that is readily compatible or a good match with you, then the other option is to go through the paired donation pool. Unfortunately, that doesn't work out for everybody, and some people still do need to go through the dialysis route, or they do have to have surgery for placement of a catheter for dialysis, whether it be hemodialysis or peritoneal dialysis. But eventually, the goal, though, is for them also to receive a kidney transplantation, either through the living donor or the deceased donor program.
So Dr. Kramer talked a little bit about the paired donor program. And this is basically when somebody has a living donor, but for one reason or another, they're not a good match. We can always find maybe an alternative person so we can essentially exchange kidneys. Now, what we are doing more and more is what's called the paired donor chains, where actually 4, 5, 6, 7 transplants can occur and they are usually triggered by what's called a non-directed donor. Now, we have people that have come to us, and Dr. Fisher is one of those who said, I don't have any relatives or friends who need a transplant, but I would like to donate a kidney. This is what they are called non-directed donors or Good Samaritan donors. The advantage of having one of those is that we can actually create a chain. That person donates to somebody who has a donor that in one way or another is not compatible or is not ideal donor. That donor on the same day donates to a second recipient. That second recipient has also a donor, and that's why they are in the kidney pair donor pool, donates to a third patient. So in this day, 3 patients have donated and 3 patients have gotten transplanted. Now the chain sometimes are more than 3 or 4 transplants, and for practical purposes, it is hard to do in one hospital more than 3, 4 transplants in one day. So what we have then is what's called the bridge donor, which is somebody whose relative, whose spouse or son or father has received a transplant, and they have committed in a different date to donate. This allows sometimes, for example, for a wife take care of a husband while they are recovering from the surgery, and then a few weeks later they come in to start a second chain, and that chain can be again 3, 4, or 5 transplants, and we can continue on with these chains as long as we don't run out of patients who match some of these recipients. So this is what we are doing these days more and more. We have already done at Mayo 175 transplants this way, and we are hoping that this will become, and it's already becoming really, an important part of what we do. It's helping a lot of people. We are maximizing the number of transplants we can do, and we're also helping facilitate the best kidney for every recipient. So what are the reasons why somebody who has a donor would like to participate on the paired donor program? Well, the first and most obvious one is for patients who have a donor who is the wrong blood group for them, or patients that have high antibodies, they are sensitized, and even though their donor may be an appropriate blood group, they don't match because they have a positive cross-match. Those patients really don't have a great option to get a transplant done, especially if the antibodies are high level. Sometimes we can do transplants when the antibodies against their donor are lower level. But if they are high, essentially the transplant cannot happen. So those people are essentially forced to find somebody else to trade their kidneys. Now, they can go on the deceased donor list, and if they have high antibodies, they probably will be waiting for many years. But if we find a living donor by another pair that we can exchange kidneys, those transplants can really happen soon. So ABO and positive cross-match is the reason why we started doing these pair donor chains, and still today is one of the main reasons why we have people be included in these donor pools. But that's not the only reason. That we have, as we have become more comfortable with this process of swapping kidneys, we find other very good reasons to trade your kidneys. There's Epstein-Barr virus. It's a virus that can cause a fairly serious disease after transplant. If you are negative, if you have never had this virus, and you get a kidney from somebody that is positive, you are likely to get a problem, basically what we call PTLD, a lymphoproliferative disease after the transplant. So you really would like to have, if you are EBV negative, an EBV negative kidney. So when your donor is EBV positive, you want to trade that kidney. Also, CMV is a similar problem. This is not as serious as EBV, but recipients that are CMV negative, and this is very typical in kids early on in their lives, they are CMV negative. Ideally, you want to find a donor that also is CMV positive, and that's one good reason to trade those kidneys. Now, as we go down the list of reasons to trade in the kidneys, age or size may be a good reason. A big young man getting a kidney from his small elder mother may not be the best kidney for him. So that patient can also offer to trade that kidney. And of course, there may be someone in the list who is very hard to match, and that older mother may be a perfect match from the tissue type or blood group point of view to the other recipient. So we find that many of our younger patients want to get a kidney from a younger donor, and they can trade off their donor for this. There's many other reasons, and these are more anatomical reasons. For example, a kidney with multiple arteries or with a little stone, where you could say, well, maybe if I offer my kidney to somebody else that really needs to trade, I can get maybe a slightly better kidney from the point of view of how easy it is to do the transplant. And finally, what we have lately been doing more is essentially offering this option to everybody. Sometimes we don't have an obvious reason to trade your kidney other than the fact that you could help somebody else. And we have found that many of our recipients are very much willing to say, of course, as long as they get a kidney that is as good as the one they were going to get, willing to trade their kidney to just help another pair. For example, it's a very common where somebody has an O donor, and people with blood group O can donate to anybody. And those people, if they have an A recipient, then that means that kidney could go to somebody that needs an O kidney, and that has an A donor. And this is a very common situation, and a lot of these patients are very much willing to trade in, as long as obviously they get a kidney that is as good or frequently better than the one they were going to get. And we are doing this not only just within our own hospital in Rochester, but as many people know, there's more than one Mayo Clinic. We collaborate very closely with the large transplant programs in Mayo Clinic Arizona and Mayo Clinic Florida. So we have created a large pool of potential donors and recipients, and we can trade kidneys. And the way this happens is sometimes we take a kidney out in Rochester, we put it in our plane, ship it to Arizona where it gets transplanted, while the kidney from Florida is flying to Rochester to be transplanted in another recipient. So we have been doing this with deceased donor kidneys for many years, but now we are actually doing it with living donors so that we can extend those pools of patients and have a better chance of facilitating this kind of transplants. We're also working now with large national organizations to basically trade kidneys with other hospitals outside Mayo Clinic. But frankly, so far, we have not needed to do this very much because we have been able to find matches with our own institution. Just a couple of words about the surgical technique. As I was saying, if you donate a kidney today at Mayo Clinic and most other institutions, you will do this through the laparoscopic technique. This means that the surgeon actually, we make small incisions. The biggest incision is about 3.5 inches, which is the incision from where we put our hand in and we take the kidney out. And that incision is below the umbilicus, below the belly button. The surgery takes typically about an hour and a half. The patient is typically for about 2 days in the hospital, and it takes 2 to 3 weeks, sometimes a little bit more, to recover where you feel that you are pretty close to back to normal and pretty much ready to go back to work and so forth. But I think at this point, I'd like to ask Dr. Philip Fisher, who actually went through this, to give us a little bit his own view and his own experience about this process. Phil?
You know, one day, this whole idea of kidney donation became personal for me. Like others, I had known there are thousands of people living and dying waiting to get a kidney transplant. But there was one day we were on rounds seeing a child that needed a kidney. Medical students were joking about how donating a kidney would help them get a better grade on their pediatrics rotation. Excuse me, before I could come back in and joke with them about that, I realized, but this isn't funny. This is something that's for real. And somehow that was my moment, the moment it hit me that maybe this is personal, this is for me, and maybe I should think about being a donor. It took the statistics and the need, and somehow that little interaction just made it personal to me. Even like for others listening today, maybe this will be the moment to think, hey, this is for me, I could do this. Or like I started thinking, maybe I should do this. So when I started wondering if I should give a kidney, I thought, well, maybe this is just crazy. So I went to a good friend of mine, Carl Kramer, and I said, Carl, am I crazy? Why would I think about this? He reassured me that even though I might be crazy, it was still an okay thing to do. So I pursued it a little more, talked to another friend that knew about kidney transplants. Then I started the process. From there, it was a smooth process, great people working through, checking me out, working through the whole thing. Was able to give away a kidney. And then about 3 months, I got a handwritten note from a nice woman who opted to stay confidential and not sign her name. But she wrote and said, thanks to the kidney, she was enjoying life and could spend time with her grandchildren. I don't have any grandchildren yet, but that kidney that's now hers is able to help her enjoy good times with grandchildren. And I thought that was pretty cool.
All right, well, we'll be able to ask more questions to Dr. Fisher later, but I think we're going to now wrap up this initial presentation. Maybe Carl can summarize some of the things we have talked about.
Just going to summarize a few things. So at the Mayo Clinic, we really try to emphasize living donation just because we think it's the best option for those patients with end-stage renal disease. Over the past, the other good approach then is being a preemptive kidney transplantation, or hopefully getting a transplant to somebody that needs one before they need to go on to dialysis, mainly just to help overall quality of life. As Dr. Prieto and myself have discussed, living donation over the past decade has become a lot easier for people, both through the surgical techniques, as well as also allowing us to find better matches and overall long-term outcome for those transplants that are actually donated to those that need them. And then finally, over the past 5-10 years, paired donation has really blossomed, and it's become a really important integral part of actually finding a perfect, or at least a really close match for those that need a kidney transplant.
And just we'll finish this with a little story. Dr. Fisher has a powerful story himself, but also just to show you a little bit. Of course, we haven't talked too much about pediatric kidney transplantation, but it goes without saying that these living donor transplants particularly benefit children. Children need to have a transplant that will last them for 40, 50, 60, 70 years. In fact, we have actually somebody was in Rochester who was transplanted about 50 years ago. So kidneys can last for a lifetime. And the way to do this is by finding a living donor and doing the transplant early. We have a lot of evidence that a living donor kidney and getting transplanted early before dialysis really is the best chance for having a very long-term good outcome. So we strongly emphasize this option as an option. Now, I'm going to tell you very briefly a story about a boy from Russia. His name is Roman, and here you can see him in this picture with his parents, Oleg and Anna. They were in Moscow, and this child had been essentially lived his entire life before he came to Rochester in the hospital. He was born with a kidney disease that essentially required him essentially to be on dialysis from birth. He came in here to Rochester when he was 11 months old. He essentially had lived in his entire life on dialysis. He was malnourished. He had a lot of medical problems, and essentially he needed a kidney. Now, he came in here with the idea that his father was going to be the donor, but unfortunately the father was the wrong blood group. This was very early in the years of paired donation, and one of our nephrologists, who actually now is retired, but he found that they were actually a good match with another pair. There was a son who needed a kidney to his mother, but they were incompatible also. So we put things together, and we figured out that the 23-year-old boy from Minnesota could actually give a kidney to this 11-month-old boy. By this time, he was a year old. And the father, the Russian father of this boy, Oleg, actually donated to this young man's mother. And here's a picture of this kid a few weeks later. It was a dramatic change. We see this in kids all the time, where this kid suddenly blossomed. Suddenly he was running through the streets of Rochester. We gave him a new life. It was a dramatic change in the quality of life and what this kid essentially has to look for. And here's a picture of the actual 4 people involved in the pair. This is a young man who donated to this little boy, and the little boy's father, Oleg, donated to this young man's mother. So really a great outcome from a pair donor program where everybody benefited and was a great thing. This kid now is 5 years old or 4 years old. So this was about 3 years ago. And we actually got a picture from Russia about when he was on his 2nd birthday, and he's a completely healthy boy. They actually moved back to Rochester where they live now, and he goes to school, and he basically has to look forward a fantastic life. And these are the kind of stories that really make us really enjoy every day we come to work, to be able to help these kids. And that's why we think living donation and pair donation can really accomplish such a great thing for all these patients. And I think with this, we're going to finish our presentation and be happy to start answering some questions. So, so the first question is about somebody that is saying, I'm being tested to be a living donor. What can I do both before and after surgery to protect my health and ensure the best possible outcome? Carl, do you want to answer that one?
So from a donor standpoint, it's typically the best outcome is just following just the normal, what we would consider to be a healthy lifestyle, mainly, staying physically active, eating a healthy diet. After surgery, periodically visiting with your primary care team, make sure your blood pressure remains within the normal range, and having anything addressed that becomes abnormal, just even if you didn't give a kidney transplant. So mainly it's just general health that you with your primary care team, even if you were not a donor. That's how you had the best outcome in the long run.
Okay, so the next question says, is it okay to take a donor kidney from someone with high blood pressure? People with high blood pressure are at risk for kidney disease themselves. So should they still consider donating one of their functioning kidneys? The answer is it depends. And in many cases, the answer is yes. We are very careful when we select somebody to be a donor. And our number one priority is to make sure that the donor does not get hurt by donating. Now, having said that, hypertension is a very, very common disease of older age. So, of course, if somebody that is 25 came in with high blood pressure and said that he wanted to donate a kidney, the answer would be no. It's fairly abnormal to have high blood pressure at a younger age, and maybe already an indication that this patient could potentially develop kidney disease in the future. And in that sense, the question is absolutely right that hypertension can lead to kidney disease. Now, if you look at the older population, people, let's say over 50, hypertension is very normal. In fact, if we all lived until 90, most of us would have hypertension. About 1/3 of the people over 50 in the United States have high blood pressure. Now, so it's a common disease of aging. Now, if you have hypertension that is well controlled, in other words, you're taking medication and your blood pressure is down to normal, and you have evidence that you have good kidney function, and then you have no evidence of deterioration of your kidney function, no signs of kidney disease, our data suggest that you are not at significant risk to have kidney disease in later years. So we feel very comfortable, and I think there's an increasing national consensus that donating a kidney in this kind of circumstances, it's safe, and we do it. Now, some programs are very, very conservative, and they say no. They say anybody that has high blood pressure, no matter what their age or circumstances, cannot be a donor. We respect that opinion, but we disagree. And we encourage people that have been told this at a different program to try one of the programs like Mayo Clinic, where actually we would say, in the right circumstances, yes, you can be a donor. And this will allow a lot of people to have their loved ones transplanted. So we feel that's a barrier that should not always be an absolute, but a relative contraindication. How do you treat sensitized patients? That's the next question. Maybe Carl can address that.
I'll address that. So that's sort of a challenging question in regards to there's many sort of variations of a sensitized patient. But I think a couple key things here is here at Mayo, we actually have two world-known experts, Dr. Carrie Shinstock, as well as Dr. Mark Stiegel, who this is part of their overall research, and they've generated a lot of excellent protocols and approaches to helping people that are sensitized receive a kidney transplant. The first step is to actually meet with these two providers to kind of figure out what degree of sensitization the patient actually has. And from there, the general first approach is actually to try and find a person that actually has a reasonable a match with that person through the paired kidney donation program, which we discussed earlier. Sometimes we're not able to find a perfect match, but we are able to find a better match than what's already been found in the past, in which case sometimes they'll use other medications and other procedures such as plasmapheresis and those techniques to even optimize it, even improve the optimization of that kidney working in that sensitized patient. So I think the first approach is to meet with these two excellent providers, kind of come up with a personalized plan, and then proceed from there regarding options.
So the next question is, how do pair donation works with international donors? Do all countries participate? Well, we transplant a fair amount of people that come from outside the United States. And in general, we tell them that getting a deceased donor, because we have a shortage of organs and because they live far away, is impractical. The waiting times are 3, 4, 5, 6 years. So it doesn't work very well for somebody that comes to get a transplant. Now, we strongly encourage them to bring a donor from home, a relative or a friend that is willing to donate. And of course, no differently than the donors that we work here, that we find from patients in the United States. So international donors are accepted just as national donors from any part of the United States are. Occasionally, we see a little problem with getting a visa to get into the United States, because sometimes they go somebody, or sometimes their relatives in the United States but lives abroad, and they want to come to the United States. And from some countries, coming to the United States is not that easy. They need to get a visa, a permission, and sometimes they have a hard time getting that. But other than that particular problem, international donors are treated the same way as national donors. We obviously make sure that the donation is being done for the right reasons, for altruistic reasons, because you want to help a relative. It's illegal in the United States to be paid to donate a kidney, and most of the world has the same rules. So we make sure that the donation is done for the right reasons. But otherwise, essentially, the process is not that different than it would be from somebody coming from California, Florida, or from Iowa. So next question is, how can I increase my odds of getting a kidney through the pair donor pool? Carl, do you want to address that one?
I think that's very individualized, because it depends on a lot of variables, including what degree of sensitization you actually are. So some people are really easy to match, others are a little bit more challenging. A lot of it depends on how sensitized you are to getting a new kidney.
Yeah, I would like to add that the way to increase your odds to getting a pair donor pool, especially if you are one of those patients who has high antibodies, therefore you're harder to match, is by finding a lot of donors. So the more you bring to the table, because you don't necessarily need to bring just one donor. If you spread the word along even social media, things like Facebook and other places, so that a lot of people know that you need a kidney and that you are hard to match, then you can basically, like if you were at Mayo, you could basically say, call the Mayo Clinic or go to the Mayo Clinic webpage, and if you offer to donate a kidney for me, we take all the donors into account that offer to donate for somebody, obviously all the suitable donors, because some people may be excluded for medical reasons. And if you have 10 people that are willing to donate a kidney for you, you have 10 times the chances of finding a match that you only have one person. So I would say that's the one thing you can do, especially for those who are, as I said, hard to match, to try to maximize their chance of getting the transplant. To find as many potential donors as possible, so we have the best chance to match you with some possible recipient. Because of course, for you to get a kidney, one of your donors needs to be able to donate to somebody else. Now, there's another question for Dr. Fisher, which is, how was your personal experience of donating a kidney? How long did it take you to recover and go back to work?
It gave me good warning. The team here was great at giving me information to make me aware and ready, but somehow I didn't believe it, and I thought I was still young and strong. I'm in my 50s, I'm not that young. And so it did take the time it said. It was about 2 or 3 weeks before I felt like I was really up and going again. Within 6 weeks, I felt all the way strong and doing fine. But I had a few weeks off, 2 or 3 weeks off work, and then working part-time and getting back and getting stronger. And other than that tiredness coming back, there were really no problems, no complications. It was very smooth, and it wasn't even uncomfortable after that. Well, not even uncomfortable at all. It was just a matter of getting my strength back and feeling strong to get to full-time work.
Let me add, now this is 2 years later or something like that?
I think.
3 years. And looking back now, would you do this again?
I've been tempted to do it again.
We won't take you.
So I thought of it when a friend needed a liver, but I didn't match for her either. And there are tougher rules about giving livers, but it's a fantastic thing to do. And even though it took a little bit of time initially, it's a great thing to do, and I would highly recommend it to anybody that's interested.
Yeah. So the next is the answer in general, of course, this is individualized for each patient, and not knowing the details, it may be hard for us to say. that basically 2 to 3 weeks of rest and slow recovery before you go back to work and so forth. And we say typically 6 weeks before you basically are fully recovered. And so 2 months is well within the 6 weeks. Is 8 weeks after. I would say somebody 2 months after donation essentially can do anything they want to do that they were doing before the donation. So 2 months should be a full, in most cases, should be a full recovery from kidney donation.
And that was certainly what I experienced. 2 months out, it was ancient history. Life was back to normal.
So the next question is, I am stage 3 in the verge of stage 4 with PKD. Can you explain preemptive kidney transplant, please, and what the criteria are for having this procedure?
So I think maybe one thing to clarify here is preemptive kidney transplant is the same procedure that you would do for somebody with a living kidney transplant or a deceased kidney transplant. It's the exact same operation. The word preemptive is just to try to emphasize that is to try to emphasize doing the transplant before you need dialysis or before you start dialysis. So the whole concept of preemptive kidney transplant is something that we like to do in children. In other words, we like to give them the new kidney right before they need to start dialysis, so they don't have to experience the trials and tribulations of needing to be on dialysis. So that's kind of the whole thought regarding a preemptive kidney transplant. And generally, we don't start thinking about that process until, you know, you're kind of in the later stages of stage 4. So your kidney function's around 25% is kind of when we would think about starting the process to look for a donor. And then once your kidney function is less than 20%, then that's when we would move forward with doing the kidney transplant procedure itself and hopefully needing to bypass that whole dialysis process.
I'd like to add in the most kidney disease, so you have time to get ready for a transplant. We typically like to see patients above 25 is premature, but somewhere between 20 and 25 is not a bad time to start at searching for a transplant program, addressing the issue of kidney transplantation, and most importantly, identifying a potential kidney donor. Now, when your clearance is 20, typically you feel fine. You know that you have kidney disease. If you have PKD, you know that that's most likely, very likely to progress to end stage. Usually by the time you get down to 10, you need something immediately. So between 10 and 20 is the time we have to get ready for a transplant. If you have been worked up by a transplant program and you have been approved for transplant, if you have a donor that is suitable to donate a kidney to you, then basically you are ready. We can do the transplant anytime. We can wait if you are feeling good. If you want to wait until next year or next summer or a few months. And in some places, people say, well, you need to start dialysis first, then we'll talk about transplant. We think that's the wrong approach. I think we need to think about transplant before you need dialysis. For example, you can avoid doing fistula surgery. Doing fistulas early, we think what we need to do early is getting ready for a transplant and finding a living donor, and that's the best approach. Now the next question is, my mother has good health and she's 72. Can she donate to my 22-year-old daughter? Does Mayo have an upper age limit to evaluate a potential living kidney donor? I'll take that one. So no, we don't have an upper age limit. We have a lower age limit, so everybody needs to be an adult, 18 or older, to donate. But on the upper end, we don't have a limit. Now, of course, as we get older, your chances of passing through the fairly rigorous donor tests is harder. And we find that many of the people in their 70s who want to be donors, they get disqualified because we find something. They have a bad heart, or their kidney function is not so as good as we thought it was, and so forth. But we have had a fair amount of people in their 70s donate kidneys to their loved ones. Now, a second question within this question is she a good candidate to donate to her 22-year-old granddaughter? The answer to that is probably not ideal. Now, if that was the only option, we certainly think that it would be better to do that transplant than to put the patient on dialysis. However, we do have a much better option, which is doing pair donor exchange, as we have talked earlier. So what we would probably do is try to find a younger donor for that 22-year-old young woman, and at the same time using that 72-year-old kidney for somebody that really would benefit from that transplant. And older people, for example, it's very common to do, typically when we have a 72-year-old donor, is going to their spouse or the brother or sister, which are about the same age. Those people don't need a kidney for 40 years, and therefore having a 70-year-old kidney, it's okay for them. So we can sometimes find exchanges where the younger person gets the younger kidney that they need for a long time. The older person gets an older kidney, but they somehow get benefit by some other situation, like a different wrong blood group or other things. So most likely that patient would, if they are very healthy and we don't find anything unexpected, they would be able to donate. Probably that kidney would end up going to somebody other than their 22-year-old granddaughter. So the next question is, what is the earliest stage that you would transplant someone? I have a family member with PKD and is currently stage 2.
So, as Dr. Prieto I mentioned earlier, generally we don't do the transplant until your creatinine clearance is less than 20. So stage 2 would not qualify for a kidney transplantation. Normally you have to be in stage 5. However, we'd just like to emphasize that when your creatinine clearance is between 20 and 25, or kind of the later stages of stage 4, when somebody brings up the topic that you need to get to dialysis, the next question, or hopefully the next sort of thought process, is also how can we get you set up to get a kidney transplant so that hopefully you don't need to go on dialysis. So if somebody talks about dialysis, they should also be talking about what your next steps are for planning for a transplantation.
And the next question is, if my 10-year-old son receives a living donor kidney transplant, how long can we expect it to last? You want to answer that one too?
So here at Mayo, we've had one that's lasted, what, 50 years you alluded to?
Yes.
So 50 years, that's kind of the extreme, but it can last up to 50 years. If you can get a good match, and during the teenage years, hopefully not have any difficulty with taking medications, we would expect it to last easily around 30 years would be the goal. So. And
the biggest problem we have with young kids is the teenage years. Kids go to school, they go away from the parents, taking their medications becomes a burden. Sometimes they have financial problems, they don't have money to buy the medications. And honestly, that's the main reason why we lose some of these kidneys. These kidneys are meant to last for many years, especially if it's a very good kidney, the transplant goes uneventfully. Those kidneys can last for a lifetime. And of course, this kidney that I was mentioning earlier that lasted for 50 years, this is at a time where we had very, very poor few tools to keep kidneys long time. What we have today is dramatically better. So we expect, there's no good reason why a transplant on a 10-year-old that everything goes well and the kid and the young adult continues to take their medications, that kidney could last for a lifetime. Obviously, it won't happen on everybody, but it certainly is a possibility for those patients. Next question. I have some medical issues caused by medication. My physician is tapering me off the medication to resolve those issues. Will I still be able to donate as long as my labs are in range?
I think it just depends on what medications and what reasons you're on the medications for. A lot of it, one way that maybe assumed is being discussed here is sometimes people are on medications and their liver enzymes are elevated, and if you come off those medications, your liver enzymes normalize, in which case, if everything else kind of fell within acceptable parameters to be a donor, then I would think that you could then go ahead and donate.
The main thing is that donors don't need to worry about or try to make that decision on their own about whether they are good donors or not. Basically, anybody that is thinking about donation for a relative or friend or just for a stranger, they can call us, they can go to our webpage, and we'll answer that question for you. A transplant coordinator typically contacts you once you give us your information, and we'll go through a thorough question and answer session where they will determine if your medical conditions and your problems, your medical problems can be would be an exclusion for donation or not. And I think that's better than trying to individually sort out by asking your neighbor or your recipient about whether you think that you could be a donor or not. It doesn't matter. Even if you have had cancer, if you have had anything, call us. You can call us and we'll tell you what are your chances of being a donor. That's the easiest way to do it.
And the team here is very good. They make those decisions. They want very much for the donors to maintain good health, and they want the recipients to do well. And they do a great job of evaluating and talking through it so they can find what works well. It's individualized enough that some risks that we might be worried about or concerned about, they might find are not risks. And I found that out as well. So it works smoothly, and they take care of resolving all those questions.
And I would like to emphasize that our number one priority is not to hurt the donor. So that overrides any needs of the recipient, any of our feelings for the recipients. In fact, the donor team typically is completely independent from the recipient's team. And we will never cut corners or allow somebody to donate if we felt that they were taking additional risks. So that's the number one overriding priority, is making sure this is the only surgery we do on people that don't need surgery. So we are very, very, very careful. We want to sleep well at night thinking that when we let somebody donate, they are not taking any unreasonable risks. So next question. My husband is currently receiving dialysis due to end-stage renal failure. He has no antibodies and we have same blood type. My chances of being his donor is good, but I have some health issues. My doctors treating those conditions have given their okay that I will be just fine for transplantation, for donation. Will I be able to be evaluated? The answer is, of course, yes. All you need to do is, if you want to come to Mayo, go to our webpage. There's phone numbers there to call, and we can essentially give you any answers. Typically, we don't do workups on donors before we do the workup of the recipient. We obviously don't want to waste anybody's time or money to do a donor evaluation if we don't know if the recipient is a good candidate for a transplant. So the process typically starts with getting the person that needs the transplant evaluated. And once they are approved and we say, yes, you should get a transplant, then is when we start the whole process with the donor. Some of the information, of course, can be done early. If the recipient appears to be an excellent candidate for transplant anyway, sometimes we can do the workup at the same time, donor and recipient, so that, for example, if they live far away, we can do the whole evaluation in one visit. But essentially, the answer is we will look at every potential donor and do a thorough assessment whether they can donate or not. So the next question is, I received a kidney and I was damaged by BK 7 years later. What can I do to avoid being attacked by BK again? I am scheduled for another transplant in May and very concerned. So BK is do you want to answer that one?
Yeah.
Yes.
So BK is a virus that unfortunately can attack a new kidney transplant. In which case, there's kind of some different approaches. Unfortunately, there's not a specific medication like an antibiotic or an antiviral out there that will completely eradicate or eliminate the BK virus. But there are some things that can be taken in anticipation in getting a new kidney transplant, or even when you get to new kidney transplant, to try and minimize that BK becoming an issue again. And some of the general thoughts or themes is maybe not use as much immunosuppression with that second transplant. That would be one major overriding theme or approach. And then the second is just make sure there's close monitoring to see if the BK actually returns back in the blood. So those are kind of the two kind of thoughts as to maybe how to address that moving forward.
Very good. So next question, and we only have time for about 2 more questions. The next one says, I would like a living donor kidney transplant, but I don't know how to ask my friends and family for such a big gift. What should I do? Well, that's a very important question. And we probably, to be honest, don't do a great job of helping our recipients find a donor, because this is a key issue. People are more and more using things like social media, things like Facebook, to try to let their friends, relatives, and family know that they need a transplant. There's several techniques, and maybe today is hard to go over each one of them, but essentially, without putting any pressure on your friends and relatives, you need to let them know that you need a transplant. And it's okay for people not to offer. You shouldn't be judgmental about those things. But the more people know about your situation, the more you have a chance of getting somebody to come forward and tell you. Like Dr. Fisher, who actually offered kidneys to a stranger, we find that there's many, many thousands of Americans who are willing to donate kidneys. They just don't know who to, and they don't know anybody that needs them. So my advice would be, first of all, find what we call a donor champion, somebody that is not you, can be your spouse, a brother, sister, a parent, who is going to take the job of educating themselves about living donation, the risks, and so forth, and then spreading the word amongst your friends, family, coworkers that you need a kidney, without being judgmental, without pushing, without pointing fingers at people saying, how about your kidney? But just letting people know what your situation is, why it would be so nice for you to get in a living donor kidney, and then let people come forward and put a step forward. Things like Facebook and other social media outlets are also very useful. You obviously need to be willing to share your personal story, because obviously if you want to keep that very confidential, this would not work. But if you're willing to do that, we find that a lot of people that you sometimes don't know so well, people that work with you, people that are your neighbors, are willing to actually do this for you. So the more you spread the news about your situation, the more chances you will have of finding living donor. And maybe one last question, which would be, when is it better to have a deceased donation? You want to answer that one?
So from our perspective, deceased donation should be kind of the last option for a kidney donation. Maybe to try to prioritize things, a living donation is, we've emphasized, I think it would be the first choice. Allows for some better planning, both the timing of surgery, potentially getting a better match. Deceased donation should kind of fall under that as a next option. And then the only way that maybe consider getting a deceased donor as a good option is if it avoids you from starting on dialysis or maybe being on dialysis for months or years on end. So.
And I think we will wrap it up here. I would like to thank everybody for your time and being willing to listen, and thank you for all those who have asked questions. We are always available, and you can go to the Mayo Clinic webpage, and there's phone numbers and ways to contact us if you have further questions, or if you are interested in getting and learning more about our Mayo Clinic transplant program. And so thanks very much for being with us, and hopefully we have been useful in answering some of your questions. Any other comments?
Thank you all very much for your interest.
Thank you.
Thank you.